This episode of EMS One-Stop is brought to you by Lexipol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexipol.com. That's Lexipol.com. Hello and welcome back to another edition of EMS One-Stop. I'm your host, Rob Lawrence, and I'm continuing the North Carolina theme. I was over at the North Carolina EMS Expo, an amazing state conference. If you get a chance to go to a state conference, I actually highly commend that you go to that one, and I'm sure our guests will back me up when I talk to them about it momentarily. But I'd like to welcome our guests from Cape Fear, and that's Tara Tucker and Dave Grovdahl. And when I was over in North Carolina, firstly, I had a chance to chat and look in the back episode of EMS One-Stop to Dave about whole blood, and we'll cover that in a second. And also met Tara, who's doing some amazing things with in community paramedicine and with behavioral and mental health. And again, we're going to explore that. And so there's some best practice coming up in this edition of EMS One-Stop. But without further ado, welcome Tara and welcome Dave. How are you?
Great.
Always great to be with you, Rob.
Thank you, Dave. So by way of introduction, I hate to, attempt to murder somebody's CV and resume and bio. So Dave, introduce yourself and tell us your backstory.
So I am a 28-year paramedic. I'm currently the EMS director for Cumberland County EMS, which is part of the Cape Fear Valley Health System in Fayetteville, North Carolina. I have been fortunate to be here for about 3 years, but I do have some county 911 director experience, some rural Oklahoma director experience, flown in Wyoming, and worked in Texas as well. So I know you and I have known each other for many years, and we are both travelers across this great continent.
Well, I firmly believe you have to move on to move up. So you're living that one. Tara, welcome and introduce yourself, please.
Sure. So my name is Tara Tucker, and I am a behavioral health community paramedic here at Cape Fear Valley. And my background was extensively in mental health and substance use prior to becoming a paramedic. And after I became a paramedic, I saw the huge disconnect between behavioral health and the EMS system, and really have a passion to make that better.
Excellent. And we're going to major in on that and focus in on that shortly. But Dave, I just want to do a quick recap. Of course, when we were up in Greensboro, we had a great conversation about blood, which was just an extension of the great conversation we had the year before, where you just profoundly and brilliantly, laid out the case for blood by saying it comes out, so we need to put it back in again. It's as simple as that, right? And of course, blood is the thing of the moment. Everybody is attempting to do it. We had a great discussion about how you set a program up. Again, go back to the previous edition of EMS One-Stop. We talked about the thing that's keeping me awake, and that's the logistics and the setup and the resupply. And you seem to have it all really taken care of. So just for those that didn't listen to our conversation before, give us a quick recap of what you're up to and the progress of the program.
So in North Carolina, we are up to about 14 programs across the state. We have urban systems, suburban systems, and rural systems that have all embraced whole blood. We were really fortunate years ago when I was the director in a government system on the coast of North Carolina. One of the trauma surgeons that was involved in the San Antonio project came to us and walked into my office one day and said, "We really need to do whole blood in North Carolina." And that was a marriage made in heaven. We were able to get a program started with the great Randy Schaefer, you and I got to talk with last week. She basically rolled out the San Antonio program. We modeled after what they were doing in Texas, and it has taken off in North Carolina. And the words we like to use here in North Carolina is game changer. Whole blood in trauma is a game changer. It is probably the one thing that we can do other than tourniquets to absolutely positively change the outcome in trauma. And so it has been embraced here in North Carolina. There have been hundreds of uses of whole blood. And so we're super excited about how everybody has embraced it. And we've got more programs coming on, hopefully over the next year.
So I know he actually listens to this podcast because he's told me. So the doc from that you mentioned, of course, is our good friend CJ Winkler, and he listens. So you can say hello and thank you to him, right? So that's cool.
And it was actually one of the trauma surgeons that worked with CJ, Dr. Doug Picorni, who was a U.S. Navy trauma surgeon, who came to us. But definitely a lot of help from CJ Winkler, Dr. Miramontes, of course, Randy Schaefer. The entire group in San Antonio was absolutely fantastic to work with. Cannot recommend them highly enough. If you're trying to start a program, you can reach out to us. I'm sure you can reach out to them. All of us are in it to win it when it comes to trauma.
Excellent. That's a great Rob expression. You've got to be in it to win it, right? That's the key thing. Before we move on from blood, of course, the issue that I asked you about last time, of course, was the one of logistics. And I think I said that if we're all doing blood, where do we get all the blood from? And you have some unique solutions.
So wonderful, wonderful program, Atrium Health, which is a large hospital system in North Carolina. One of the blood bankers actually was contacted by one of our team members and with our NC Blood Coalition, and they came up with this great idea that the hospital blood bank could provide the blood, basically retain ownership of it, through contract, could give the blood out to the ambulance service. And then over a period of time, if the blood didn't get used, it got cycled back into the hospital. It's great to see that we are partnering with more than just our emergency departments. We can partner with our blood bankers. We have to contact and be in communication. And it is one team. We are absolutely one team. The whole blood is a team sport. So work with your emergency department, your trauma service. Don't forget your blood bank. They are huge. I would highly encourage anybody who is interested can reach out to me, and I can definitely pass along the blood bank information. But this is going to be another one of those game changers, to coin and use that term over and over again. Working with the blood bank can definitely help out those programs who are having challenges getting blood. Blood is difficult to acquire. I think we have solved that problem in our rural areas here in North Carolina.
Wonderful, and game changing will continue to be the theme. Also, I think there's a paper recently published by Dr. Matt Levy out of Baltimore, again on the logistics and the setup of whole blood programs. So there's a number of references out there. If you haven't considered doing it, there's a lot of people you can speak to. There's a lot of documents you can now get a hold of. Final question on blood, though, Dave, is again, it's almost like the classic Rob/COO question: who the hell's paying for it?
So that is the great question. You know, at the end of the day, when it comes to EMS, we know we're all underfunded, and so where are we going to find the money for this next great project? And so, if your state does not have a blood coalition, start one. There are some great blood coalitions going on. Florida has a great coalition. North Carolina has a coalition. I believe Texas has a coalition. That those statewide coalitions partnering with our national blood coalition, that's power. Numbers are power, and we are petitioning CMS. We're petitioning anybody who will listen to us to get the rules changed, that we can make blood an ALS2 intervention. And so we can get reimbursed with an EMS, but we have to have the programs, we have to have the numbers, we have to have the data. We are on a mission. We have a great big coalition with a lot of great people working on this. I think it's going to be something that will get done in the near future.
So, Dave, first of all, thank you for all of those wise words. There's some great takeaways already here, and we haven't actually got onto the main subject, which we're going to do right now, and talk about not just community paramedicine, but obviously in Tara, Dave, you have a behavioral health community paramedic. And so covering a lot of ground there. So how did, obviously, you set up the community paramedic program, and then when did you branch off into clearly a very needed area, because of course it's a lot of our call volume these days, into the behavioral health, mental health speciality?
So, being a good director, we looked at our call volume and are trying to figure out how are we going to answer all of our call volume. We can't continue to put up more and more trucks there. The economics of it just don't work. And we all know that. We've got to find alternate ways of doing things. And so we started looking at our call volume and realized that mental health, substance use. Those were a large part of our call volume and across the entire age spectrum. And so we decided as a system that this was going to be an important initiative. We're hospital based, so mental health service line is a big service line within our health system. And so we knew we needed to do that. And so it started with going out and finding the right people to be a part of that program. And I've had the pleasure of knowing Tara for several years. At a previous program, we worked with her. And so it was a matter of picking up the telephone and saying, "Hey, Tara, got this really great idea. I need somebody to take the football and go 100 yards with it." And I couldn't think of somebody who was better suited, somebody who has the background information, and somebody who is absolutely has the tenacity to continue building this program and coming up with new and crazy ideas that have panned into some really great projects. And Tara will talk a little bit more about that.
Well, we're going to talk to Tara in a second. Dave has set Tara up very nicely, but first, let's have a quick word from our sponsor.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
Thank you to, once again, the amazing voice of Jim Dudley, who is my voiceover specialist and also the voice of Policing Matters over on Police One. If you get a chance to listen to Jim with his amazing guests, switch over. Once you finish this podcast and vodcast, of course, to Police One and have a listen to Jim. Always interesting stuff happening with our law enforcement brethren. So we're here and talking to Dave Grovdahl and to Tara Tucker. But before I come back in, make sure, please, that you hit like and subscribe on the platform that you take your social media or your video in. Don't forget, we're not only on Amazon podcasts, on all the Spotify's, on all the audio channels, but we also go out on YouTube as well, on the EMS One YouTube channel. So not only can you hear us, but you can also see us. And as I remind you every week, you can then see the images of whatever it is we're talking about. And I can guarantee that we have some great images for you on this podcast. So if you're listening, switch over to YouTube, and then you can see what we're talking about. So we're back with Dave and Tara. So before we went to the break, Tara, Dave set you up nicely and some amazing accolades there. Obviously, you have a behavioral health background. You came into this, you are the paramedic, the community paramedic, and obviously you're out there delivering this service, out in the community. So give us the sort of setup and the backstory for the program that you've created.
I think one of the things that was really significant in my background was I worked on what was called an assertive community treatment team, or ACT team. And it's designed as a multidisciplinary treatment team to work with people that have the most severe persistent mental illness and addiction issues. So working and addressing that whole person for a period of 10 years. I also had experience working inpatient, right? So seeing what people look like when they are really sick, and then going out into the community and knowing how to navigate the resources. So ACT teams are designed to be a hospital without walls. And I think that's really a good description. What all do you need to do for a person to keep them out of the hospital? So that's kind of that mental health background, working in the MCO world that Dave was talking about, the managed care organizations in North Carolina that drives a lot of the behavioral health system for people that are underinsured or have no insurance. And understanding how to navigate that background, I think, has been really helpful. We'll talk about that some too when we talk about some of the funding, but it just really gave me a great background for community paramedicine, in my opinion, especially the way that we're doing it with having a social worker and a peer support specialist on the team, right? Those are disciplines that I'm used to working with over my years.
Of course, we'll come on to reimbursement again, and as everybody knows, we only get reimbursed for taking a patient to a hospital. We know, and I've certainly had conversations on the left coast where people say, "Well, you, the medics, are bringing us the wrong type of patient." In other words, you're taking behavioural health patients into the ED, to which there then becomes almost a logjam in terms of working with them and actually coming up with a disposal for that patient. Obviously, you're out in the community doing that. So, A, how do you get your referrals? And then, most importantly, and I've said this for decades now about community paramedicine is only good if you have the pathways in which to refer people down. So, how does the program work in detail?
So I think that you bring up a really important piece, the framework, right? If you don't set up the relationships with all the community partners, you don't have places to refer people to. And I think that is something that I have taken the time to really extensively build, because there's a variety of things that we run into, right? That people go to the emergency room for that really we could handle much better out in the community. So that framework, I feel, is really huge to community paramedicine. And I think that's where it's helpful having that diverse background, right? Knowing all these different community partners to engage in this work. As far as where do our referrals come from, our crews can make a referral in our PCR system, but we also go a little beyond that and pull some reports as well that I think are important. One is that overdose report, right? So that we can follow up with people post overdose, trying to get them options, right? And one of the big things that we do is, if you're not ready for treatment yet, we still give you resources that show we care, right? For example, the Never Use Alone hotline, and teach you, if you're going to use and be by yourself, here's a phone number to call. They stay on the line with you, and they call 911 if that line goes silent. So those kind of things show people that I really care about you as a person. And so many folks with addiction issues don't have that, right? They don't have the people that care. So that overdose report is one. Another one is our suicide report, because EMS runs a lot of calls related to people that are having suicidal thoughts or suicide attempts. They get dropped off at the emergency room, but what really happens from there, right? And are we addressing, maybe it's financial issues as to why they're feeling suicidal, maybe it's relationship issues. Are we really dealing with the root of the problem? And if not, we're going to run those calls over and over again, and people get frustrated, they run them again, right? So we're really trying to address the social determinants of health. A lot of times are a piece of what's going into that call related to their suicide. And then we also deal with youth that have mental health and substance use issues. So understanding things like adverse childhood experiences and that trauma early in childhood does affect a person, right? And the need to get them connected to services related to that trauma. Parents that have addiction issues, it affects that youth, right? Youth, we see the rates that substance use is increasing. I mean, now kids that are saying their first age of use is 12 years old. I mean, that's huge, right? So we need to get those kids connected earlier, and we've worked with those behavioral health providers to be able to do that and really have a good workflow with that, and great relationships. So we even have a youth mental health team that will respond out to the 911 scenes with our crews and try to get things started. So that really is kind of the 4 areas of focus that we have. Obviously, the crew referrals end up being a lot of case management. That's what we're seeing.
That's great, and you answered the question or the challenge perfectly. As I said, the pathways are absolutely key, and you described them. One of the things that I've done in a previous employment is to actually, and this may sound a little bit morbid, but we worked with the medical examiner and looked at the deaths again of relative youth. And then we cross-referenced that against our own call volume to see how many times, and there was times, how many times we'd actually been to that person, that patient before, and then try to work out, well, what went wrong this time for overdose, should I say? And then we asked the question, well, what went wrong this time? And actually, it's because that when that person was visited in the first or second times, it was because someone had found them, and then it was, the last time, or the time that caused the mortality, was that person had gone off somewhere else to inject, infuse, breathe in alone, right? And so we were able to, again, comes back to some guidance and advice. We know people are going to do this, but we need to make sure that they're as safe as they can possibly be if and when they do. And that was kind of one of the areas that we certainly worked on with the medical examiner. So pathways, fantastic. So Other than crew referral, though, so what data sources are you using in order to, extract the intelligence to enable you to do the job?
I think a lot of that is just our PCR reports from our PCR
Yep.
system and looking at those. Trying to obviously decrease the number of suicide-related calls, decrease the number of overdoses. We're seeing actually a pretty significant decrease in our overdoses, which is great. I mean, it makes a difference when you offer people the right kind of treatment early. So many folks say they go to the emergency room and I wanted help and I asked for it, but that's not the specialty of the emergency department either, right? So I think, I mean, for me, that's one of the most rewarding pieces of my job, being able to get
Yep.
people connected to treatment, right? And see the change.
So are you a team of one, or is there more of you?
So there actually are 4 community
Excellent.
paramedics, a social worker, and a peer support specialist, which is that person with lived experience.
Great. Now, talking about lived experience, one of the programs you told us about before we started recording is you have a very unique group that are out there helping you, supporting you, offering, almost peer guidance, peer support. So I'm not going to do a spoiler here. So talk about who else you're working with out there.
So this is one of our really unique partnerships, I think, and we're partnering with a group of bikers called Broken Chains, and they're all people in recovery themselves. And they really just meet people where they are. They love on people and try to address social determinants of health with us. We'll talk about our monthly outreach event, but one of the things they do at our monthly outreach event is cook the meal. And, food's important, but they hand out Narcan and being able just to say, hey, I've been in those shoes before and change is possible. That is a huge message that they give. Hope is real, change is possible, and you can do this too, and we'll help you. And they also, a lot of them are a part of some type of 12-step program, either Celebrate Recovery or Recovery Alive. So they engage people into that recovery program. And so many people we see need a support system, right? Their families turn their back. We work with a number of folks that are homeless. They need some support system. And so that support from them has been huge. But they've really rallied with us and, as Dave says, take on my crazy ideas. One of the things they just actually had a conference, and so they created suicide prevention patches that have 988 on them because we're finding people still don't know about 988, and it's a much better resource, right, than 911 for mental health issues. So they had, they were a little skeptic. They printed 100 of these patches. They sold out in the first day, and have other biker groups that are wanting to get those patches as well. They've created I Carry Narcan patches and really try to get Narcan out in the community. So it's been just a unique partnership. I think, one of those innovative things that people don't always think about partnering with.
Well, Tara and Dave, I want to join your PR club here and tell them to get more patches ready because we're going to make this a thing because I think it's an amazing idea. Now, you touched on 988 and it's coming up for possibly a couple of years old. It kind of came into existence by when we went, hey, 988's here. I think they may have assumed initially we all had behavioral health, mental health teams that deployed like you, but believe me, it's not everywhere. How are you interacting? And SAMHSA are doing a great amount of outreach now as we get into, midway through 2024, and they have been doing for some considerable time. But is the program, the process, the referral, the call 988 coming through to you, all that kind of stuff, is that working well for you?
Right now, we have it integrated with them because we have so many referrals with our call volume.
Okay.
I mean, with the suicide-related calls, it's around 100, 105 a month. Overdoses, we're getting around 250 a month. So, I mean, our numbers are just way too high to integrate with them, I think, at this point. Obviously, we want to focus on the things that our crews are seeing.
Okay, a great honest answer, and my friends at NHTSA Office of EMS will fully acknowledge that we're doing a lot of talking, liaising, and getting together at the top to work out how we can better integrate. So that pretty much reflects the story at the top to the story that you guys are doing. We mentioned data sources, and I think, Dave, you were telling me that you are about to indulge or engage in the NAMSP long research course.
So there's a lot of great resources out there, and probably the one that I'm most excited about is, of course, NAEMSP, the National Association of EMS Physicians, have a QA/QI course. And Typically, you can only take that course at the NAEMSP conference. We were lucky enough that Remley Crow, we reached out to Dr. Crow, Mike Tagman, and Dr. Joey Glover, who happens to live just up the street from us, about an hour away in Raleigh, and reached out to them and asked if we could do the QA/QI class here. And so we're going to host it locally in August. And so really applying the principles of QA/QI so that we can help dive into our data, better understand our data, and pull out the important information. And so knowledge is power. And so we've got to get through all of that ESO data that we have at our fingertips, and really learn from what the data has the ability to tell us. Shake that magic 8 ball and let it tell us what the future holds for us. And so super excited about that QA/QI.
You're a man after my own heart, Dave. As we all know, data is my favorite 4-letter word. So that's, and also I do believe that Qua Qui is actually the amazing EMS martial art. And so become a practitioner at it, QA/QI. So as we come to a close then, just to kind of round out the topic, and it's been an amazing discussion, and hopefully we can have a lot of resource in the show notes for people to either follow you or to really work out what's going on. Certainly go back and look at the last edition of One-Stop where we talked about the whole blood, but I think the behavioral health, mental health, and the community paramedicine aspect of this is phenomenal. Is there anything I've forgotten to ask or anything you need to tell me?
So I think one thing I'd like to add is the outreach events that we're doing each month. So again, focusing on that framework of partnerships we built, we offer an outreach once a month, and all these partners come together to address needs of people. So it may be things from getting them signed up for Medicaid or food stamps to haircuts. And I mean, it's amazing just the difference a haircut can make and somebody being able to get a job, right? And that partnership has been fun, but it's a way to look at being more proactive instead of reactive, which is typical for EMS, right? And try to keep people out of the hospital emergency departments because we're able to address the true needs there.
You're doing exactly what we should all be doing, and that's working out how we can keep that person that doesn't need to go to hospital out. Dave, any final thoughts?
Yeah, I have 3 points. The first point, take from the great Matt Zavadsky, is, reach out to your resources in your state. We know funding is a big issue in community paramedicine, that we're not quite funded. But reach out to your insurance carriers. Insurance carriers are set up by state. Reach out to your local insurance carriers and start the conversation with them. They will actually help provide funding for programs. We have funding through United Healthcare for our outreach events. We are in conversations with our insurance carriers through, luckily we have an ACO, so we have the ability to talk to them on a different level, being hospital based, but have those conversations. They are willing to fund these programs, but they're state by state dependent. So have those conversations with them. The second point is as sometimes as paramedics and EMS services, we want to try to handle everything ourselves. Partnership is the key. Partnership. So don't try to be the end all be all for everything. Our own team is partnered. We have a social worker and a peer support in addition to our community paramedics. Use the power of all of those different skill sets, and use the partnerships in your community. You don't have to be the counselor and the provider of all the social determinants. Partnership with those agencies. And I think third, and probably to me the most important, is don't immediately take everything off the table. When Tara came to me and said, we're going to partner with a biker group, my initial thought was, why? But it turned out to be the greatest partnership ever. So the wild and crazy ideas, way back when you and I started, right? 12 lead was this thing that probably wasn't really legit. I remember when 12 lead came around, it was a crazy idea. Ultrasound, crazy idea. Whole blood, crazy idea. No, there are no crazy ideas. There's just self-imposed limitations. And so don't be afraid to try things. Failure is a step on the road to success.
I may have just aged myself, Dave. In my day, it was 3 lead, just saying.
So you and I both, sir. Life pack 5.
I don't need to offer a summary for this particular edition of EMS One-Stop because Dave just did it beautifully. Those 3 steps are things that we should all take heed of and take note of. So the time has flown by, and it's time to say thank you, both of you, for joining me today. There's some amazing takeaways, some glorious sound bites, and some things people need to act on. So a superb show. Thank you for joining me. And I know that we can follow you, and I'll get all the notes, put them in the show notes, how we can get in touch, how we can follow you, your organization, etc. But for the moment, both of you, thank you very much for joining me.
Thanks, Rob. It's great to see you as always.
Thanks for having us.
So don't forget, like and subscribe, whether you're on a video or an audio platform. And then, of course, what that means is every time an episode of EMS One-Stop drops, you get notified that we're here with some amazing content, like the content we've just listened to. So that's it for now. This was EMS One-Stop. I was Rob Lawrence. My guests were Dave and Tara. And until next time, bye for now.